now.
Welcome again to the Brain and Mind series on our youth mental health model, our enhanced youth mental health model for better care. I'm Professor Ian Hickey, the Co-Director of Health and Policy at the Brain and Mind Centre, and my colleague, Professor Elizabeth Scott from Teambased in Sydney and Notre Dame Medical School, where we have developed this model in partnership over many years. This is the 5th webinar as part of the series, this time looking specifically at what service model, what service system is required to support the key elements that we've been discussing through this series. That of highly personalised care, and that combine that with measurement over time to ensure that people are receiving effective care. The whole point of this particular seminar being you can't do it on your own. What's the service system you're in? What services does it work with? And then how might you bring that all together? And in particular, how might you need the assistance of other things like technology for that to really work? As in each of the other seminars, I'd like to start by acknowledging the Gadigal people of the Eora Nation, whose lands the Brain and Mind Centre at the University of Sydney is based, and their centuries of experience in working on the social and emotional well-being of people who live in this country. And acknowledge also those with lived experience of mental health difficulties and their families. So this is the 5th in the series, focusing on support and delivery models. And we'll discuss particularly the models that Liz and I have worked with, as with Headspace, Enhanced Care Services of Brain and Mind, the services that Liz has established through the Holt Street multidisciplinary clinics with mind plasticity and association with inpatient services, Use-Space, working across a whole spectrum of services to see whether we can improve the care that is delivered to people with different needs over those periods. So just to recap the 4 previous seminars briefly to reinforce the same concepts, since repetition is essential to learning, even for us, just keep reminding ourselves that in all of these particular issues, we're trying to treat the current situation and then prevent actually the development of more complex disorders, that our assessment framework is multidimensional. It isn't just preoccupied with diagnoses and boxes we were discussing last time, but also with the wider social and occupational functioning, self-harm and suicidal behaviours and preventing further self-harm and suicide, comorbid drug and alcohol problems, and a strong focus on physical health over time. That we see this within the context of clinical staging and important innovation in our clinical approaches to these particular areas, the constellation of syndromes over time, particularly in early phases, to potentially prevent their progression to more full-blown or stage 2 disorders and the progression on to more typical descriptions of psychotic, anxious, depressive, or bipolar spectrum type disorders. Within that, there are 3 particular mechanistic pathways we're interested in: neurodevelopmental pathways you see through childhood and then expressed in association with adolescence with further cognitive, social, and often psychotic experiences. The arousal, hyper-anxious kids who are anxious kids who become anxious and depressed teenagers and likely to become anxious, depressed, substance abusing adults. The most common pathway we see through these particular areas. And the circadian or rhythms pathway, disturbances of sleep-wake cycles that you see often in association with the development of rhythms in children and attentional difficulties in children, progressing on to the more disrupted periods of sleep-wake cycles and mood-related disturbance that we commonly see in the bipolar atypical spectrum over time. So although we talk about the thing being transdiagnostic, we've got some pretty clear ideas about particular pathways that people may be on, and we integrate that with stage of illness. You can be at stages. And the goal to be, of course, earlier stages where things are less clear-cut to develop still quite personalised treatment programs. Doing more to get measurements straight. So actually recording these multiple dimensions and these complex issues over time and using much more standardised measurement. So not just using repeated paper and pencil or repeated personal narrative, what can be done in terms of using standardised instruments, and increasingly the extent to which we can use more objective measures, the laboratory measures, brain imaging measures, neuropsychological measures, to follow consistently over time what is actually happening, and developing a much more systematic approach to measurement, to standardisation, and then taking that forward into the key concept of measurement-based care. My favourite idea, I don't care how you got better, But if you didn't get better or you got worse, then we've accurately tracked that over time, what treatments you received, what was the nature of the problem, how it's interacted with other sets of issues over time, so that we have a much more complete picture for anyone who's involved in the care of that particular young person. And then the previous seminar, we really got down to the N=1, what treatment selections you make at different stages of illnesses. For earlier stages, the treatment selections being the ladders that assist people to get out of holes. What are the secondary prevention strategies to keep them out of those holes on an ongoing basis? And how you combine multidimensional assessment, the notion of clinical stage, and these subtypes of mechanisms to make those individual selections over time. Now that, in a sense, in those 4 previous seminars is a lot to get your head around and try and do it. If you're trying to do all of that as a standalone practitioner in a service that doesn't really consider who it's treating, what point they're at, what is its immediate goal, what is it working with, how is it going to achieve those functions, it's really hard. So we've tried to give quite a lot of thought and action and activity over the last 15 years to, can you build service systems that would actually respond to this type of model? So here we want to discuss that. What are the elements of key service systems? What are the things that are not in place most of the time? And what might you need to have in place to actually make these things work? Early recognition, so there's an early intervention focus, independent of age, which treats the problem and tries to prevent progression. You know, that's the whole point of early intervention. Less toxic, if you like, forms of intervention, less risky forms of intervention, but the possibility of preventing progression. Incorporating other evidence-based processes. And one of the most important of those is real-time measurement-based care. Always of medicine, the better use of measurement-based care means that less people come to harm and more interventions occur at a timely place. So we're really tied to the concept of right care first time, which is followed by, if we didn't get it right the first time, we want to get it right as quickly as we can in relation to that N=1 personal experience. Another key concept for us is multidisciplinary teams, and it's worth stopping here and taking into account. Liz, although you're the world's best psychiatrist, who else do you need to work with to make this worse?
The world's best team.
Which consists of?
So we've been very fortunate to work with a number of different practitioners with different skills and to build kind of teams over time. But essential part of that have been mental health nurses who are highly skilled in looking after young people in particular and across the range of kind of physical and kind of medical and social kind of interventions. Occupational therapists.
That's nurses with a go-get-em strategy too. That's not nurses sitting in an acute psychiatry unit or behind glass in an emergency department or not going anywhere. That's a certain kind of nurse.
Those are nurses with very specific sets of skills.
So they're mental health nurses.
Yes.
With a go-get-em attitude.
With a can-do attitude.
Can-do attitude.
With a can-do attitude. I can do that. I can help the young person. I can help them with physical activity. I can help them to find their GP and make sure that they get their medical tests done and that are followed up appropriately, that they can treat their social help to initiate exposure therapies for social anxiety, that they can really operate across the whole range of
But they've also got strong
strategies.
physiological skills. They are nurses.
Yes.
Right? So in addition to the doctors, which may include the GPs and the psychiatrists,
Yes.
the effective use of nurses
Yes.
in chronic disease management
Yes.
that understand physiology
Yes.
as well as the mental health components you're talking about.
Yes.
Big factor.
Absolutely.
So we've made a lot of fuss here about physical health, follow-up. There are issues, of course, in our world related to medication adherence, medication side effects, attitudes to medication. Look, the doctor told me to take it, but I don't want to take it. What do you think? Best often asked and discussed with nurses, and I must say with other people in our world and other research we've done with pharmacists and others. I don't really believe what the doctor said, and I don't really want to take it. What do you think? And that kind of working with people about what their attitudes are to medical therapies or even having to receive treatment for their mental health problem. It's often been nurses or sometimes pharmacists or others who understand those physiological aspects who actually do a really good job. So that's kind of critical.
Oh, nurse practitioners, let's not forget them as well, who can actually order pathology, write scripts, who actually do hold a whole knowledge about the person across a range of areas. Occupational therapists are absolutely critical. The occupational therapists, again,
the practical people
who, if you have young people, as we do with a lot of school refusal, who've taken to their rooms or their beds, can actually go and provide more home-based intervention.
So it's OTs with a go-get-em attitude too.
It's OT with a go-fetch-them attitude.
Fetch them attitude, right.
Which is really important.
And a strong functional focus. Throughout this
Absolutely.
whole seminar series, we put a lot of emphasis on social and occupational function. Often it's the OTs who are more functionally orientated
Yes.
than anybody else.
Yes, absolutely. And again, cross that range of kind of mental and physical health kind of problems, but also extremely good at interacting with families and doing some of the, you know, the kind of behavioral interventions and support that families require to be able to support the young person to be able to function better.
Okay, so we've got
which
nurses,
is a gap in our system.
Nurses, mental health nurses,
Yes.
nurse practitioners, OTs.
Yes. Psychologists.
Now on the psychology front.
Now on the psychology
Who's your favourite
front.
psychologist?
So the psychologists who have this is just not about the care that I deliver in my clinic. It's about how I work with a team to promote the goals of the whole team.
Right.
So it is less about the individual kind of care of the person, psychological therapy. It is really about that, how that fits in to the whole care plan for the person. So
But can we dwell here on skilled clinical psychology
we can.
and skilled psychological therapies?
We can.
So who the best clinical psychologists we work with, who are fabulous,
Yes.
are highly skilled.
They're highly skilled across a number of modalities. So they're not stuck within one particular, they don't just do ACT therapy or CBT, or they don't just do interpersonal therapy or psychotherapy. They actually can adapt their skills for the person. They can personalize their care. And that does require experience, requires good training, but it also, you know, also the experience of working with systems over time.
There's another belief in our area, and I don't know really where it comes from, except I've been accused of being an adult psychiatrist, which I suppose is a bad thing, of not wanting to work with families, with social workers or psychologists who do family therapies or family interventions, or even family education in particular ways. So of those range of professionals who work with families, would you just like to kill that myth?
So we had I'll give you an example of the myth, which was in our young adult unit. The myth was these are young adults and therefore they are individuating for their families. Therefore, we only need to treat the young person, and families should be
Kicked out.
Kept behind the door.
Familyectomy,
because it's all about individuation. We had to quickly review our views about that and say actually families were invited through the door, and that they were actually a really important part of the treatment process, that you could not treat the young person in isolation from their families unless obviously they had moved on and they had individuated, that really we were dealing with the kind of system that the young person operated in. And that has meant having different skills. It's meant a lot of different ways of spending time, and it's been incredibly rewarding and helpful. And I would say that the advantages in terms of recovery over time are well worth the learning the skills and taking the time.
Right. So rather than say we adult psychiatrists or others don't like families, I think I'm going to remark on two things here, which of course is the Western psychological tradition of individual psychological therapies and the intrapsychic world as being entirely personal and not shared. It's interesting in our introduction to this series, I'd like to mention and talk a lot, if I wish I knew more about it, about really what social and emotional well-being in Indigenous cultures really means. But one of the things that's critical is, in fact, not seeing the individual as an individual alone. And the intrapsychic world is not entirely cut off from everybody else. Of course, in many other cultures, the issue of shared issues, an issue of ever seeing a young person on their own would be a ridiculous concept. You would be seeing the whole family. You would be seeing groups of people in several waiting rooms and therapeutic rooms. There are lots of chairs. There isn't just one other chair. There's lots of chairs. My assumption being if a family and people turn up and they say, do you want to see the young person first? I go, no way, let's see everybody. You know, you would deal with the whole situation. And I think it remains one of the issues for us in the skilled teams of professionals, that willingness to engage with families, the wider social system. And of course, I'm alluding to there the cultural competence to deal with a wide range of attitudes and beliefs that exist in different groups, in different family groups, in different cultural groups, in different social groups that we need to. So, we left out general practitioners. I didn't mean to leave out general practitioners, other medical practitioners and other medical specialists we work with. So working with GPs are often part of our particular models, critical in terms of attending to medical and psychological constructs, but particularly issues around, again, drug health, issues around sexual health that become particularly important, working with other people who come from a drug and alcohol background, and then working with other medical specialists as we need to, as we quite often work with immunologists, endocrinologists, neurologists, any other ologists we've left behind, cardiologists,
pediatricians,
developmental pediatricians,
yep,
particularly in the area of some of the neurodevelopmental disorders. So I think this issue about having teams that are fit for purpose, and the team may not be in your clinic. You might have to see the team structure as not just being what do we have internally. So I go to lots of meetings of different groups and they say, I need more people in my team. I go, hang on a second, that person's sitting exactly across the corridor in another team. couldn't you just change it to mean you could all be part of the one team, the one circle of care, not just having more and more people 0.1, 0.5, 0.5 in a particular group and not seeing the wider group. So for us, teams is not just the group in your clinic, it's the wider group of people you really do work with.
Yeah, and that includes education and vocational support.
Right. So just moving from the health bit, two of the other really important groups within those teams are education support, obviously in the school, but also in the post-school environment, universities, vet training, and employment support. So classically, you'll see in a number of Headspace teams around the country and elsewhere, people who are working from employment in individual IPS programs in terms of the individual placement of the individual who come from an employment background, two critical kind of other areas. One of the things we'll see in the future, I hope, is the so-called digital navigators. You'll see people who assist people to use technology. Now, they may be youth-specific workers or what are known the Headspace things as youth workers at the moment or youth in other particular areas. So the team structure is one of who is it that is fit for purpose to really work in partnership with the young person and their families to achieve those goals. That may well increasingly include peer workers as well in those particular structures, people with their own particular lived experience. Depending on the age of the young person and the particular setting in which they work, it's a little bit different to peer workers in some other adult team environments. But that actually issue of working with other families, other parents, other young people who've had similar experiences within that team framework is one of the areas of development of mental health. So all of that hopefully translates to it isn't just what I do as a psychiatrist, as a psychologist, as a nurse, as a GP to try and solve the problem. I think if I read one more tweet this week about what I need as a GP or what I need as a psychologist or what I need as a psychiatrist, and I don't mean to just emphasize those three professions, but endlessly, and then something pleading, special pleading from their organization that, you know, we, whoever we are, do most of the work or we are most essential, I think I might become even more upset than I usually am and say, look, it's the wrong construct. It's not to devalue in any sense the individual contributions or the individual skills. In fact, I'd say it's the opposite. We want to value the skills of those individuals, but together they are much more effective than arguing individually about what they do, or worse, arguing against each other, one trying to discount the roles that others may play, which has been a characteristic of a lot of the discourse in mental health. You don't need medicines. Medicines are bad. You shouldn't use psychological therapies. They don't really work. You shouldn't go back to school because you really should not be at school. You know, it's all sorts of things. Oh, you should throw the family in, you throw the family out. You know, all sorts of dialogue that we've had that's quite contested in our area, most of it incredibly unhelpful. Okay, and then the last issue within the issue for this particular seminar is another issue which is about actually using mathematical modelling to plan. Imagine that. We actually planned our services to be most likely to benefit a young person. What things are most effective, not just the adding on of everything. The danger in our area is just to add everything on. The classic, and I hate to say it, but biopsychosocial model just adds biology to psychology, to sociology, to everything else, and says if you chuck everything in, it'll all somehow be better. Don't believe that. There is a kind of issue trying to work out at the service level, and then increasing at the individual level, what is the combination that is most likely to be effective? So we can talk about that in individual clinical care all the time, but we can talk about that at the service level as well. What sorts of things really do deliver? Or to put it the other way around, services that don't have educational or employment support don't tend to deliver good functional outcomes. Services that don't attend to drug and alcohol problems don't tend to have good outcomes in those particular areas. Services that ignore physical health tend to have a lot of physical health complications in those particular areas. In the work that we've been recently publishing, services that lack skilled psychological and psychiatric care on an ongoing basis don't deliver good outcome. High clinical skill also matters. So there's some of the particular issues, and how do you hold it all together? Information technologies, trying to hold all these things, having people working together to the same script, to the same outcome measures requires systems, not medical records. I can't find the records. What did she do? I don't know. What did the letter send? I don't know. This morning I had to see a man who's seen 10 other psychiatrists. Does anyone know what medications he's been on for the last 10 years? No idea. And he's asked to remember. He said, I might be able to go and find from the pharmacist eventually. You know, critical information gets lost all the time because we're not working with information technologies. 21st century information technologies, you know, stuff that can digitally track and record what is happening to the person plus what interventions they're receiving. So When we talk about the individual elements, which we've been talking about in the previous 4 seminars here across what we're doing in terms of assessments, and then we're doing real-time measurement, here in this particular seminar, we're saying that it sits within a system. The person receiving care is in fact in the healthcare system. Now, we have many investigations in mental health. This year's Productivity Commission, this year's Victorian Royal Commission, to follow on from many other previous over the last 25 years, generally says the system doesn't function, or there is no system, in fact. But one of the responsibilities in this area, particularly in the youth area, has been to try and grow systems of care along with better actually models of care. So pick up from one of Liz's young patients.
As a mental health consumer and also as a mental health peer support worker, I've seen the difference between poor and also good quality mental health care. And I think that better mental health care really does make a difference, particularly in my own life. I've seen how much more I've gained from seeing clinicians who have cared more, who've given me more hope for the future, compared with others who haven't, and also, clinicians who've been keen to explain evidence-based treatments to me. And technology has also been huge, just listening to music with different emotions and being able to listen to podcasts to block out unhelpful thoughts, just a whole range of things, and connecting with others has been extremely helpful.
So Liz, Travis is alluding to
humour and also as a mental health peer support.
Travis is raising a really important issue there, which is about demoralised things. He's talking about systems that give hope, clinicians that give hope. And I'd also make a comment about systems that give hope, going to places which are fundamentally inquiring, enthusiastic, optimistic, and the staff being there. It's distinct from going to places where everyone tells you how hard it is and they're trying their best, but really it's a hopeless system that they're kind of working in. Do you want to just comment on, demoralised staff within demoralised systems, translating no hope? It's a contrast, it's a black and white here between those, and we've been fortunate to work in, I think, where people are trying to build new systems, but also their own optimism is driving an optimism, hopefully based in reality, to actually build better systems. And working with an invigorated system, a system that you're trying to remember, it makes a difference then to the sort of comments that Travis was just making.
So I think it is really tough for people in those systems, in that either in the sense that they feel that they're not able to provide the care that the person needs, or they feel that the care that they're providing is as good as it gets. And therefore, when people present with complex issues, as Travis has, for instance, many of our young people have, where the combination of kind of, physical health, complications and having very kind of chronic and persistent symptoms, I think it's easy to feel, oh, well, this is all that we can do, or this is as good as it gets, so we just have to live with it. What Travis is alluding to is the fact that we have continued to work with him to try and maximize his health and to try and provide continuously look for opportunities to help him improve and help him drive his recovery. And that has translated into Travis trying to do the same thing for other young people as a peer support worker. So I'm really fortunate, I think, that, and the team that I work with, that we have this capacity to continuously inquire and continuously work with people and work across systems to help translate research into clinical practice rapidly. I would really like other teams to have the opportunity to do that. We have had very consistent teams we've worked with over long periods of time who've maintained their enthusiasm and their care for young people, and I think reflects the fact that. But
just on that comment, because people say, oh, well, okay, when the government builds such a system, or when the health system does, or the hope will do it, then I'll do it.
Yep.
Do you want to comment on the other way around, which is really the clinical leadership here?
Yes.
I mean, no health administrator, no health funding system builds a functional, enthusiastic, competent system. Just on the role of clinical leadership to actually make systems better.
Yeah, I think that is absolutely right. I think it requires strong leadership, and that also, we hope that through these training webinars, we'll be able to pass on some of those things, that it is possible. What actually is possible? It is actually possible to work in multidisciplinary treatment teams in the community, outside of public health systems, which are flexible, which are innovative, and which are collaborative. And that is a joy to work with, and it is possible. And we're now getting, there are different funding models, and I think funding through, for instance, we have funding through private health insurance to actually provide more community-based care. There will be more hospital in the home care. So I think there will be other funding models that will drive this in the future.
Well, as come to it, philanthropic, there's family, there's others, where because there's been clinical leadership, other people are prepared to invest in new models. If you're waiting around for someone to turn up to make your service better, not going to happen.
It's not going to happen.
The issue is whether the clinical leadership and the skills we have, we actually show what can be done, and then hopefully have that be taken up more widely as standard practice. So in the service systems we're talking about for this enhanced brain and mind youth model, just over on the left here, the question of assessment being multidimensional, actually being critical. So good information comes in. Then what you see there is service level review and treatment planning. You've got to see the right person first off. If you have a complicated issue, if you are in a really crisis situation, if it's a situation that really is well beyond the skill of a youth worker, a psychologist with minimal training, a GP, then you've got to have a really skilled clinical psychologist or psychiatrist or a really skilled nurse practitioner involved early together and plan what's likely to happen. Not just put everyone into the same sausage machine and hope that eventually it'll discriminate in those who require much higher levels of care, more complex care in the first instance. And also then provide basically individuals with our best guess in the first instance of who they'll need to see and actually how long that will need to continue for over what sets of periods. So for the staging model that we have concepts about what may require very light care, might require supervision, maybe largely dealt with the technology, right through to the later stages, which immediately require more complex team care, and are going to continue that for the next 2 to 5 years. And to know that, so you're providing realistic sets of systems to the person and their family to feedback, and that is monitored. And that's monitored not just at the individual level, but at the service level. Do you actually know in your service how many people get better? Do you know how many young people you see from different demographic backgrounds? Do you know what the outcome of the actual care is? Are you actually able to compare the severity of what's coming in, or do you have a simple dumb caseload system? I got 10, you got 10, they're all the same. They're not all the same. And not all the services see the same degree of complexity. Complex interventions for more complex cases is what needs to happen. And we need to be able to review that and see we're on the right path. There's a constant dialogue in mental health and in psychiatry particularly about how bad we are at things. We're not actually that bad at things. We're actually quite good at things over time. We need to be able to actually review the situation constantly in order to actually make sure that the right people are getting the right care. And so the monitoring allows us to do that. And when people are therefore better and have received appropriate care in a planned way, not in a chaotic way, but in a planned way, they can move on to secondary prevention and other recovery-based processes outside of the clinic framework that will continue with the understanding if things go wrong, they may need to take in again and be reviewed again. In the post-COVID world that we are now in, we are also trying to look at the ways in which technology can actually flip the clinic so that we don't have the dumb things we've had in the past, which are waiting lists of people who can't get in, can't get the right level of care, are all treated the same. And as any individual clinical system becomes more popular, essentially the waiting list to get care gets longer. End result of that, those in more emergency care end up in emergency departments and elsewhere, not coming into systems as we would wish them to in less severe states. But it also means the wrong allocation of care. Everyone ends up getting the same simple GP assessment, simple youth assessment, simple 4 or 6 or 10 sessions of psychological therapy, and using that process then to simply sort out what people might need. Lots of people end up with bad care for long periods, poor care, ineffective care, costs the health system more, but most importantly, from a young person's point of view, is ineffective. In our view, technology can be used immediately to provide young people with information to support the multidimensional assessment, to bring a person into care in particular ways, and people can do a lot of that online. You don't have to ask a whole lot of a young person a whole lot of questions. They could have answered online. You could know the answers and saved your time and their time to get on with the next set of issues. Triage in this level is a service level focus. about trying to get to the right person at the right time, and then planning care in relation to clinical stage. After that, then tracking care and continuously reviewing. As I said earlier, if you get better really quickly, great. What I'm really interested in is if you're not getting better, or even more importantly, if you get worse after you come into our care system, do we actually respond? You need to have the mechanisms in place. You need to have a service system that has that model, not a service system that says there are 50 more people to be seen in the next month. So we'll see 10 this week and we'll see 10 next week, while the top of the funnel just fills up again with more and more people. And then shorter and shorter episodes of care are provided because of the pressure we're under. In the post-COVID-19 world, we're going to face an increasing demand for services. More people are going to come into care, and we need to deal with care more efficiently so that those people who need the most care get it quickly. So what we're trying to do here is talk about the service level connection between what current clinical stage a person might be at, what the current clinical need be, which is not just a staging issue, it relates to issues like functional impairment and risk and other sets of issues, and have a fairly good idea about the type of care that people might require then on an ongoing basis. So those at earlier stages may well, with self-care and care-directed monitoring management use of technologies, actually be able to largely deal with the problem themselves. Be monitored, but not require a whole lot of clinical intervention or a whole lot of multidisciplinary care. For those, again, are at earlier stages, but with again, fairly low degrees of need, they may, in fact, be able to be dealt with low-intensity clinical services and appropriate matching of technologies. As the stage goes up and the clinical need goes up in relation to risk, functional impairment, etc., the degree of intensity of services goes up, including right up to acute and ongoing specialist community services. So we should have in our mind different levels of care for different people. Your traditional clinic that says, nope, you're going to see the psychologist, or nope, you're going to see the psychiatrist, or nope, you're going to see the GP, doesn't tend to allocate the care appropriately. It tends to get people in and then continue care as long as the person wants to come back till they stop coming back, or basically just continues with care. Many, many mental health systems have no output. They have input and no output. What happens? The system stops. They end up taking care of the same number of people, and the capacity to take care of new people and have people transition sensibly through the service actually doesn't happen. And when people receive bad care or inadequate care or poorly personalised care, they tell other people bad care. I was in a debate in youth services recently. How much bad care? Whenever I say there are instances of bad care, people go around, you can't say that because most people get good care. I said, well, what's the evidence of that? If you look at the data that we have in most care systems, about a third of the users of the system and about half of the families of those systems say the care isn't very good. Now, I hear a lot of apologists in mental health go, well, that's not too bad. 2/3 of people thought it was okay. And half the families thought it was okay. So isn't that good enough? No, it's not good enough. And a lot of the issue relates to the fact that we have trouble getting our head around the fact that we have to allocate the care more efficiently. Those who have greater needs have them met. Those who can move systems through fairly quickly and receive the care they needed can also have that met, but that to be understood and transacted. So Liz, do you keep everyone for life? I mean, we've seen a lot of patients here that you've got 10 years old, you've seen 15 years. Does that mean you just simply keep everyone that comes in the door and keep the other 35 who are waiting?
No, I mean, Travis would be a good example of that, of somebody who came into care at some point, who has been, got to a level where he has been able to work with his GP with, very kind of minimal follow-up, but at other times may come back into care. But for many, many people, we are able to provide a level of intervention, and then not necessarily discharge them, but send them out with the capacity to manage their well-being, to monitor,
come back if it goes bad,
and come back if it goes bad.
Rapid re-entry.
Correct.
Haven't forgotten who they were.
No.
Don't start again.
It's
not a game of snakes and ladders. It's not a thing where if you suddenly get somewhere and then you fall back again, you have to go back to square two on a snakes and ladders board and start all over again, which is the experience of many people. And again, very frustrating when there's in their system, lack of continuity of care over time, although the intensity of care may quite vary at different points. In a technology enhanced circle of care, we're trying to make this much, much more clear in the way in which people can come into care, the ways that they can be assessed, the way that technology can enhance assessment, and then the extent to which people can be followed over time, bringing really into play much more clear team-based care strategies, whether we've used screening that's online and used video assessment online, which services enter into a service, particularly a youth-based service, and how that's then monitored, the extent to which with technology, online tools, video conferencing, video visits can be actually reinforced, and particularly in the newer world, that the issue of shorter but more frequent actually context using technology may be a more effective way of delivering care than simply line up. And I'm so busy, I've spent 45 minutes of your day, but I can't see you for another 6 weeks, which is a very common kind of thing in many individual services. But actually, we don't need to spend that amount of time, but actually I am working with the mental health nurse and the OT and the educational support, and 3 or 4 more people from our team will be in contact with you this week and next week while attending to tasks and organising that, while the more specialised roles of the psychiatrists or psychologists do take place at appropriate intervals. So actually bringing these things into more organised care, again, technology may be one of the ways of making that more obvious. And also being more clear where there are points. You can see down here at 3 months, 12 months, 24 months, where are the review points? Where are the checking ins of what happens? Early in the course, might be a matter of days, once people have recovered over the next particular months, depending on the stage of illness that they presented with in the first place.
Every time I was asked to tell my story, multiple things would be left out. I think the worst thing, though, is I became desensitized to how horrible and traumatic my experiences were. Every time I was asked to tell my story,
it is almost worth playing Sam's story several times. We're going to hear this several more times. It's the most frustrating thing in the world. Man, I saw this morning having to ask him again, and he's seen many other people. Does he have any idea of the number of medications he's taken in relation? He doesn't have any idea, and he has no information and none of the information systems that he's been party to, because they've all been medical records kept by 10 different doctors in 3 different specialist clinics in different places. There's no continuity. So sadly, started my own day with asking him to tell the story again. And Sam's point is really interesting. That's often a very traumatic thing to do. People have had really difficult experiences, and to go over it again, not be explained, not know which treatments actually worked, which ones caused adverse effects, what treatments were never provided, like where are the gaps, where's the misunderstanding, what assessments were never done in a particular country, was consideration ever given to neuropsychological assessment, to brain imaging, to metabolic screening, to physical health problems. Oh, I don't know. My GP might have done that, and I did see somebody else, and what's my physical health got to do with it anyway? Or what has happened? And then in another series of things that we've been involved recently, people saying, well, what about people's actually childhood history or their lifetime history? And what about the role of families? Well, whether you like it or not, your mother might have important things to say about you, or your wife or your partner or anyone else might have quite important things to say about you. The potential in the various systems, particularly technology assisted systems, for other people to put that information in, to make it available. So not having to always interrogate the same person, as Sam was just alluding to, who's very sensitive about their own experiences and go over the same experiences again. Often, of course, family, and for young people, parents and others, may be able to provide that information very quickly and efficiently. Again, they don't want to tell the same story over and over and over again. I think it's fair to say, Elizabeth, we've dealt with a fair number of anxious, frustrated parents, and dare I say it, the odd angry, hostile dad. Are we really going over this again in a particular situation? So you just want to comment from that point of view about being put in a situation where you just have to ask because the information is not there?
And it's like having to remember your bank account details and all the transactions that you've done. I mean, it makes no sense in a technological world where all of that can be recorded. I think it's very obvious in hospital systems. When people get admitted to hospital, they often deal with somebody at triage, they deal with somebody in ED or PAC, they deal with somebody else on the ward, the nurse, and then the registrar, and potentially the consultant, might be the allied health staff. They continuously telling their story over and over again without necessarily feeling that they get a lot back from it. So I think this is one of the things that could be rapidly changed by this kind of integrated health, information technology that would make a huge difference to people and their families.
And I think the point that Sam alluded to, and I think the young people have actually and not a word to be used lightly, but are being traumatized by it. I mean, difficult things have happened to young people. And I think, you know, when people are admitted to hospitals, we kind of understand they've been traumatized, but they've been traumatized by many aspects of the interaction of experiences and things that they've been through. And having to be asked again about the last suicide attempt or the last admission to hospital or the family factors that have contributed to this or the difficulties that have arisen and the experiences they've had, being dragged back through psychotic experiences again or other things. It is re-traumatizing. And yet we just sort of take it as normal practice to be uninformed, because classically we do inherit people as they move through different levels of systems where we are relatively uninformed by what has happened previously. So,
and information gets lost all the time.
And wrong information.
And wrong information gets
So for any of you who are dealing with the Australian My Health Record situation, and I've dealt with this with a number of consumer groups and with young people, the information that's in there that's been put in by doctors that is wrong and has been entered and wrong and is not open and transparent with the consumer. So it says thing about the person and it says something wrong. Of course, once it's in the medical record, it's said to be right, must be true, as distinct from it doesn't lend itself in a slightly more Wikipedia-like way to being revised by and have input from the young person in this case, or the family, or by others who have other information. So smarter systems can deal with these things. And just to re-emphasize, they're not medical records. They're real-time health information technologies that are relevant here. And again, very few people have experience of dealing with those. The one that we are working with at the moment is the Interwell platform, developed with the support from the Australian government, and we will go into this in further detail, in the next seminar. But it does attempt to bring together a variety of these different concepts that we've been looking at in real time, and to hold that in real time so that it can be shared continuously between the different service providers that are involved. So they might all be in the one agency, or they may be in multiple agencies, but also are open and transparent with, in fact, young people and their families. So what do you think about that idea, Elizabeth? Being open and transparent in the record keeping that you actually have. Many clinicians go, you've got to be kidding. We cannot. And I'm tied up in this at the moment with several services and several hospitals who are going, no way. We can't tell the person what we did and what we recorded. We can't share the record.
So the record might actually belong to the person.
Yes, what an interesting concept. Is it? Well, it's certainly about them, and decisions are being made.
Yep.
Of course, in the ownership, all the health systems claim they own the record, although they say they perhaps are obliged to share that in certain circumstances. But that idea of that we are in any of these systems hiding information, but we're using that information to actually make decisions. So in an own debate I was in recently with clinicians in this area, I said, you know, but this is the basis of you making a decision. They went, that's right. I said, so how do you explain that to the person? The basis for making the decision? Aren't you going to go on and actually explain? They went, yeah, I suppose I am. But I still don't want to share what I wrote down. So, well, what did you write down? You know, some pejorative thing, some horrible thing, some inaccurate thing, what? But there is this kind of idea of the privileging of knowledge and the retention of knowledge by professionals, rather than actually sharing critical knowledge, correcting it, maintaining it, and keeping that continuous information systems live that holds us all accountable for what happens on an ongoing basis. We live in the 21st century. We don't have to use papers and pencils and files and lost communications, and dare I say it, even the fax these days, to actually transfer information and bring it back into real-time decision-making in these critical situations for young people. So the systems we are working with seek to integrate information as you move between systems. You'll see a whole lot of the top here brands that we're used of in Australia, including YouthSpace, one of my favourite ones, for the Youth Mental Health Service at St Vincent's, but others, where the goal here is to have information not get locked away in one of these balloons and stay alone, but information that can be shared between services. So no matter where a young person needs to go, an information system actually could take the information with them. So if you came in through Headspace, but you end up in YouthSpace, or you're dealing with other particular sets of issues, that you could actually make use of their technology, or using an online system from Origin, that could all be available at the same time wherever you were. The smarter back-end systems had the potential to do this. They also had the potential to bring in information and other assets, tools for your sleep-wake cycle, for your health and well-being, for yoga, and for, as Travis was talking about, for music, for relaxation, etc., to join other social groups like Hello Sunday Morning for controlling alcohol use, or pursuing other things like Kick It for quitting smoking, all range of things that exist in the wider world into those same systems so that information is collected for that. For example, out of Fitbit type systems around your physical activity can be brought into the same information system. The information systems are available. The problem is our willingness, in fact, to incorporate these things into our clinics and our practices on an ongoing basis. Really problematic, since really we still exist largely in a paper and pencil, horse and cart type age when it comes to health information systems. There's an important issue down here that in all the systems we're talking about, the end user, the patient, the young person, etc., is in control of what actually is the transmission of information. People still want to be able to control where information. They may not necessarily want to tell everyone everything all the time. So that within such systems, you can have levels of control. So ones that commonly arise, people may not want to share aspects around their sexual history or certain aspects of their drug and alcohol use with everybody. But working on those issues together, we can often get effective sharing of relevant information.
I have told my story more times than I can count. I think it's so important to do this. Hopefully someone can learn from my experience. If it's a doctor who could hopefully apply a treatment better or faster, or if it's a patient who just finds comfort in seeing someone at a different stage in treatment. And when retelling my story, I think I forget bits and pieces, or I remember bits and pieces, but the true core of my experience is always there. And I think anyone who truly wants to understand my illness or what has the impacts of the treatment, it's not just about understanding the patient, understanding my experience, because my experience is quite unique. It's also about understanding the people around me, the people who were affected by my experience and supporting me. So my family and my friends, they have a very unique perspective. They have a very different perspective to me. And I think to understand the impact of the illness and how to treat the illness effectively is to understand not just the patient, but those surrounding and supporting the patient.
I think we're just going to hang on to that smile at the end. Sarina was a young woman with a very complicated illness. This is a woman who still has a complicated illness, very unwell at a very early age. And the issue that she raises, given it's such an interesting thing, she experienced such a high level of distress herself. She was so unwell. But we did always see her and involved in management, her mother, her sister, her father, who had marvelous insights into the systems, and contested views between family members about what might be in Sarina's best interest at different stages, where there were complex decisions to be made and there were real risks to be held. People who genuinely cared for her and could actually interact with the things. So it's really interesting for this young person who really had suffered such a great deal of distress herself to see her be so sensitive about that particular system. I think it'd be fair to say along the way, not all members of the services that she ran into all the time kind of understood that or necessarily incorporated her family in the way that she would have liked to into her continuing care. So seeing that wider impact of the particular kind of issues are so important. But Sarina's an excellent example is of the number of different people that have had to be considered part of the team for her to end up with that smile on her face.
Yes.
Do you want to just dwell on that for a moment about the complexity of who needed to really be involved in her care?
I'll just say one thing about her story. Sarina took about 3 years before she could actually tell her story to anybody, before she could actually say what was going on.
That's right. She couldn't speak.
She couldn't speak. So the fact that she now really, is able to articulate about what happened to her, I think is really important. She comes and helps me give lectures at university at Notre Dame, and she is one of my most powerful tools in terms of education, because her story that she tells is of not being listened to in the emergency department, of her family being excluded, and how that impacted on her care, to not have her family there to help represent her.
When she was unable to articulate.
And she was unable to talk for herself. Yeah. So she was a really good example of the danger of excluding family. Yeah. She was a young person who was really lucky, fortunate to survive, I think, and she realizes that, which is why she feels her family is so important. In the basis of recovery and survival, some of the really critical people were not necessarily myself or the immunologist or the cardiologist or the other people we had to get involved in terms of her complex care, but it was the person who provided her with education support, who actually got her back to TAFE, who helped her work with very significant cognitive impairment through the process of staying in TAFE, passing her exams, coping with a lot of the physical health problems that she had, which really impacted on her capacity to now be able to go to university and to be almost, well, part way through of her university degree. She would not have been there without that wraparound care that she got from the whole team, from education support, from occupational therapy, from the mental health nurse who saw her every week over a prolonged period of time to help coordinate her care.
Keep going. And the complex medical therapy
and the
range of services, inpatient and outpatient.
And
the other thing to
family
say
intervention
for that was the number of service points at which you've been so-called assessed. And I count in that not just mental health services, but a range of other medical services to say, well, it's not what we treat. End of story. Hang on a second. As she was a girl at school at the time, a very bright girl, obviously with some major disorder developing, who was in stacks of trouble, simply to say, it's not, whatever it is, it's not the one we treat, therefore exit our system. You know, to see it in such narrow terms. And that in a sense, many of those were in very reputable hospitals, in very reputable places. Just the kind of failure of any systemic approach of what might be required to work in a complex situation, to not know. I think we were asked on many occasions, what is wrong? We go, we don't really know, but that's not really the point. Whatever it is a complicated set of medical, psychological, developmental kind of sets of things in a particular kind of way. And that continuity of story, the reliance on family to be part of that, but actually not to have to go back over ground where even she was unable herself, even if she could, to actually do those particular things. And keeping track of the complexity of her illness, its treatments, its complexity over time would be impossible without a strong sense of system and who is the team to deliver best care in her situation. I can just move to the next slide if I do that without restarting Sarina again. Yep, there we go. So the particular youth model that we're talking about, in order for it to be delivered, it has at its heart a movement away from simple, dumb, stepped care models. Everybody can get the same thing. Those who fail, go to the next level. To get the next dumb thing the same for everyone, those who fail, go to the next level, if you still can be bothered with us and sticking with it. Of course, for young people, a lot of step care is based on adults who are kind of like, you know, institutionalized. They will keep coming back to healthcare, generally speaking, even though healthcare fails. So the kind of, you know, primary care rule, send them away, you know, cautious optimism, you know, watchful waiting, see what happens. If it's really bad, they'll come back, has been well demonstrated for young people not to work. That is the quickest way to lose people who actually require a lot of care. So that dumb stepped care approach doesn't work and it's dangerous. We would recommend this more highly personalised, measurement-based care. It's got to right care first time and then follow people in care to make sure that what seemed like the right care actually delivers, because for a proportion of people, it'll turn out to be not the optimal care and they will deteriorate or they will not improve, in which case the measurement-based care will ensure that we actually step in, reevaluate, reassess, and provide the team that might be created. For all of this to work, everything is local. The famous saying goes, all politics is local, all healthcare is local. There has to be a service system sitting around where you are that understands its primary care, its secondary care, its partnerships with general health, its partnerships with alcohol and drug, important one you mentioned, the importance of partnerships with education and with work in order to achieve those particular sets of issues. Even when you are most unwell, many people would prefer to be at school or at work to actually get through the day than to be home on their own, abandoned in their own head on an ongoing basis. So local systems, and in our view, local systems are driven by local clinical leadership. They're not endless coordination meetings between services and service directors who make agreements, to have service agreements that are never fulfilled. I don't think in my life I can sit through one more of those meetings. I'm interested in the clinical leadership of meetings actually agreeing to work together around individual cases like the ones we've highlighted today. Sarina and Travis and Sam would all be excellent examples, like Josh, other ones we've highlighted through this series. Teams of people, teams of skilled clinicians have come together cooperatively to take care of those needs of those young people. And then finally, the issue to say, really for this to work in the 21st century, really for information, because you see in each of the cases that we've highlighted that Liz and myself, or mainly Liz, has been involved in caring for over the last 5 or 10 or 15 years, the continuity has been essential. The failure in the past has been loss of information and discontinuity. The health information technologies can make this much more possible. They can allow a lot more people to incorporate into that, a lot more information to be shared. And the issue of further technologies is one that we will take up in the final of the seminar series in the next series. So, thanks for your attention today. And as I was just saying, the last in this training series, we will put to air next week, and it'll focus on specifically how to maximize the use of technologies within these new models for care. Thanks for your attention today. I'd just like to say that continuing professional development points are available, and also like to thank in particular those who support us in this work, Future Generation Global, which is a bunch of investment banker type people who support this work. They want to invest in Australia's future, and particularly the families of a number of the individuals and others that you'll encounter throughout the series who really have the wish that the excellent care that they've been fortunate to receive would be able to be shared through others through a further development of these education and training seminars and resources. Just to emphasise, if you want to get a hold of the best summary of our particular work, it is in the Medical Journal of Australia supplement from last year, and we're happy to provide that to you if you email us, and in association books and publishings around clinical stagings and youth mental health. But hope to see you again next time for the final seminar in this series.